Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network at the UNC Lineberger Comprehensive Cancer Center. Thank you so much for being with us here today. We really appreciate that you've taken time out of your day to join us for this Community Lunch and Learn lecture. Just a few things to tell you before we get started. If you're having any technical difficulties, please don't wait. Call us right away at 919-445-1000. You can email us at unccn@unc.edu, but the phone is really the quickest way to reach us. We're on the web at unccn.org. We're on Facebook. We're on Twitter. We're on YouTube. So lots of places you can find out more, and we'll talk about that just a little more right at the end. Okay, we're going to be using Poll Everywhere today, and this gives you an opportunity to anonymously go ahead and answer a question, and then even more importantly, to be able to ask questions at the end of Dr. Rivera's presentation today. So what I'd like for you to do is, if you're at a computer, any web browser, even on a smartphone, you could go to pollev.com/UNCCN, and you'll see our questions and you can answer them or ask your own there. If more commonly our audience likes to use a phone and text these in, so one time only you need to go ahead and text to the number 22333, the letters UNCCN. So 22333 is the number, and you'll send in the letters UNCCN. After that, you'll get a little message back saying join, and then you can go ahead and answer our poll here, and then after our poll, you'll be able to text in your questions at the end. We'll see those and respond to those as time allows. So if you'd please do either go to the PollEv website or text that in, and then our question for today is, according to the American Cancer Society, lung cancer is here's the blank, you're going to say the first, second, third, or fourth most common form of cancer in men and women in the United States.
Oh, okay.
And so we'll go ahead and share that with us. Sounds like we had somebody just join us who's not muted. So if you would please, if you're just joining, go ahead and mute. Thank you so much. Sounds like you already took care of it. All right. So without further ado, I want to welcome our guest today, Dr. Rivera. Dr. Rivera, Thank you.
Thank you for
Very
having
glad
me.
to have you here today. Patricia Rivera is a professor of medicine in the Division of Pulmonary Diseases and Critical Care Medicine at the UNC School of Medicine. She joined the multidisciplinary thoracic oncology program at the UNC Chapel Hill as its director in 2004, and has served as a professor of pulmonary and critical care as a professor in the Pulmonary and Critical Care Division. Her research focuses on the early detection of lung cancer with the use of the life imaging fluorescence endoscope. Patricia completed her doctorate in medicine at the State University of New York at Stony Brook.
Thank you for the
All
introduction.
right, absolutely.
I just
Anything I
wanna
left out?
Well, I've actually been at UNC since 1995.
Oh, I'm so
That's
sorry.
irrelevant, yeah.
We will update our
That's quite
records.
all right.
Thank you for clarifying.
I was brought
that.
on to help build the multidisciplinary thoracic oncology program.
Right.
And, yeah, 22 years.
Good for you. Good for you. We still have a remote site that's having a little trouble there with muting, so just want to remind all of our audience members, please make sure that your computers are muted. We'll go ahead and try to mute you from our side as well. But I don't want to hold us up any longer, so I'm going to, first we'll go ahead and take a look at Poll Everywhere and see what we've got. So if you think that the answer is first, go ahead and put in an A. If you think that answer is second, put in a B, third C, and fourth D. So let us know what you think here.
100% responded
100% at A, and we'll wait just maybe 10, 15 more seconds in case anyone else. Okay, now we're neck and neck.
Okay.
All right, we're getting equal representation here on all of these. Clearly, no matter where our answer falls, this is a very significant form of cancer in terms of its impact on the population in the United States. What is the actual answer here?
So actually, lung cancer is the second most common cause of cancer in the United States in men and women.
Okay. So very, very high, very significant. And without further ado, lung cancer with Dr. Patricia Rivera. Let me pass over the
Thank you.
the keyboard and the mouse, and should have everything you need.
Very good. Well, thank you very much for inviting me. And today we will talk about lung cancer, an overview of some of the risk factors, the diagnosis, the staging, and some of the treatments that are now available. A lot of progress has been made in this disease over the last 22 years. It's been slow, but it's been steady, and really significant changes that are making an impact on outcomes in our patients. So we'll advance that lung cancer is a common cancer, but it's the second most common cancer in men and women in the United States and in most parts of the world. The majority of lung cancers are called non-small cell lung cancer, and the second most common type of lung cancer is called small cell lung cancer, and they differ by the way they look under the microscope, under the microscope, how they present.
I'm sorry again. We just again, if we could remind all of our participants to mute. Looks like Outer Banks just came on. It's possible that Outer Banks is not muted, and if we could ask you to mute, please, we would really appreciate that. All right. Sounds like we are all set.
Thank you. Lung cancer, as I said, is the second most common cancer in the United States in men and women. It's much more common in African American men in the United States. This is a high risk group of patients for this disease. Lung cancer, however, is the most common cause of cancer death in both men and women in the United States and in most parts of the world. And African men in the United States have the highest risk of dying from lung cancer. If we look at death from other cancers in the United States, again, lung cancer accounts for 28% of cancer deaths. So many more lung cancer deaths than colorectal cancer, breast cancer, prostate cancer, and pancreatic cancer combined. Over the world, this is a significant problem, not only because of the incidence, about 1.8 million new lung cancer cases every year. Lung cancer results in 1.6 million cancer deaths throughout the world, more cancer deaths than tuberculosis, malaria, and HIV. So this is a serious problem, not only because of its high incidence rate, but also because it causes so many deaths. There are many risk factors for lung cancer, and many experts in this field believe that the risks may be what we call multifactorial, in other words, and multiple risks are playing a role. But by far, the most important risk factor for this disease is tobacco exposure. Outdoor pollution has also been implicated, and much of a problem, but still something to be very, very attentive to is secondhand smoke. Lung cancer has a genetic predilection. If an individual has a first-degree relative, so a mom, a dad, a brother, a sister, with lung cancer, they are at increased risk of developing lung cancer. If an individual has had a prior tobacco-related cancer, let's say a head and neck cancer or esophageal cancer, these are cancers that we know are linked to tobacco, they're at risk for developing lung cancer. And when we think about lung cancer risks, we always have to remember occupational exposures, and by far the most important and the best studied is asbestos. People who smoke, who develop injury to the lungs and develop COPD, chronic obstructive lung disease, are also at increased risk for lung cancer compared to smokers who don't have COPD. And also people who have fibrosis or scarring in the lungs are at an increased risk for developing lung cancer. As I mentioned earlier, although there are multiple risk factors and lung cancer risk is probably a combination of risk factors, by far the most important is smoking. And currently in the United States, about 25% of adults continue to smoke. When individuals stop smoking, when they quit smoking, the risk of lung cancer will decrease. and it will decrease with every 10 years that that individual is smoke-free. It'll never go down to the level of a non-smoker, but it will decrease. That's why it's so important for patients to be helped and get treatment for tobacco, because tobacco, we consider it a disease, not an addiction, so that they can try to get rid of tobacco smoke. It's very unfortunate when we look at smoking rates, while 25% in the United States, this is significantly improved over the last 50 years since 1964, when the first Surgeon General warning came out about the risks of tobacco. But in many, many countries in the world, South America, in Asia, the rise of smoking among adult populations is increasing significantly. Here are some of the common or described occupational factors that may be linked to lung cancer. And again, the most important one, and the best studied one, is asbestos. But radon, silica exposure, nickel and arsenic, all of these agents have been linked to to lung cancer risk. Now, lung cancer in women is probably a little bit different than in men in terms of risk. It's interesting, the number of lung cancer, or the incidence of lung cancer in women, and the rates of death from lung cancer in women has steadily been increasing significantly since the 1960s, not just in the United States, but throughout the world, and particularly in some parts of the world like China. This is becoming a major problem. About 10 years ago, experts in the United States labeled lung cancer in women a contemporary epidemic because of this increase in the number of cases and in the number of women dying from lung cancer. It is the leading cause of cancer death in women in the United States, and in Europe it surpassed breast cancer as the leading cause of death in 1982. I just want to go back and make a point that lung cancer can develop in non-smokers. Again, the most common risk is tobacco, and 85% of lung cancers are linked to tobacco. A small percentage of lung cancers will occur in non-smokers, and it's often women non-smokers. And there's a whole host of reasons why that may be. I don't know if we'll have time to discuss that in this lecture. About 15%, so a small number of patients who have lung cancer will have no symptoms. And the cancer is detected because an X-ray is done. Let's say the patient is going to have surgery, knee surgery, and they have an X-ray. Or they have a CAT scan done for some other reason. They're in the emergency room and they're having abdominal pain, let's say, and a CAT scan gets done. So about 15% of the time, patients don't have symptoms. But most patients who are diagnosed, or at the time of diagnosis of lung cancer, will have symptoms, the most common being cough, and a cough that doesn't improve. And we usually say that a cough that's persisted for 4 to 6 weeks needs to be investigated. Coughing up blood is associated, or it's a symptom of lung cancer. Shortness of breath, feeling like all of a sudden I am not able to do as much as I used to because I feel breathless. Having pain that's unusual anywhere in the chest or in the back or in a bone, the back, the hip, the shoulder. Headaches can be a presenting symptom for people who have metastatic disease or spread of cancer to the brain. And what we call non-specific symptoms of unintentional weight loss and loss of appetite. And that can be seen with a host of medical conditions, but it's something that we pay attention to in someone who we think may be at risk for lung cancer. Although rare, sometimes lung cancer patients will present with unusual symptoms that are conditions called paraneoplastic, so associated with cancer syndromes. These syndromes are more commonly seen in patients with small cell lung cancer. Small cell lung cancer is the least common form of cancer, and it's the one that more commonly will have these paraneoplastic syndromes, and the most common of these syndromes is presenting with a low sodium or too much cortisol, or people who present with unusual symptoms of imbalance or what we call neurologic symptoms. Individuals with non-small cell lung cancer can present with an unusual change in their nails known as clubbing, where the nail beds get puffy, if you will, and that's a very characteristic finding. It's not just seen in cancer. There are many other conditions that can present with clubbing or can have clubbing as a feature of that disease. But when we see it in a smoker and we suspect lung cancer, that's important to follow up on. Also, patients with non-small cell lung cancer can present with high levels of calcium. That's also a paraneoplastic syndrome. The lungs, and I'll just use my mouse here, are usually, we can on an x-ray compare the right to the left lung. Human beings are for the most part pretty symmetrical, so what we see on the right lung is pretty much what we see on the left lung, with the exception of these structures here in the middle of the chest, which are the vascular heart structures. Here's the heart and the aorta. Right here we can see that this looks different than this. We appreciate that there's a density, a more brightened aspect of this x-ray, and that turned out to be a mass. Or we can see, for example, a rounded density like this. This was also a mass. These are all x-rays of patients of mine who presented to the emergency room for a host of reasons that were found to have these abnormalities. Different types of findings on x-ray. Sometimes lung cancer will present with a shadow that has a hole in the middle. We call that a cavity. And squamous cell carcinoma of the lung is the one that commonly can do this. So a host of different things that can be seen on the x-ray that the radiologist will alert the doctors and say, hey, I see something here. And if a patient has a cough and fever and is producing sputum, we might treat with an antibiotic, but the important thing is to repeat that x-ray and make sure that that shadow has gone away or improved. When we suspect someone may have lung cancer, or we're evaluating a shadow that we see or an abnormality that we see on an x-ray, we will go ahead and get a CAT scan. It's a much more detailed image of the lung. You can see the lungs and all of the structures, and we can see things like this large mass here with a cavity or a hole, or this mass here, which is not a cavity, but it's a regular. Lung cancer tends to be irregular. It's not perfectly smooth and round, but see how it's kind of bumpy, lumpy. This is a very unusual type of lung cancer that presents almost like a pneumonia. This is what we call nodules, like rounded densities. And this is a large mass that is involving the left lung and spreading into what we call the mediastinum, the middle of the chest, where the lymph nodes and the vascular structures appear. A very important part of the evaluation of a lung cancer patient is a test called a PET scan. And the PET scan is a test that uses a different type of imaging technique than a CAT scan. Patients are injected with a dye, if you will, that's disseminated throughout the body, and then we can take pictures that from the skull down to the legs, and we look for areas that are dark or black. When the cells are rapidly changing, they can't get rid of the PET dye and they trap it, and then we see this kind of blackened, very dark images. Although you will see the darkened images in the bladder and in the kidney, because those are organs that are getting rid of the PET. The PET is very helpful because it helps us find cancer in other parts of the body, and that's what helps us determine if the cancer has spread. It's very important in terms of making decisions on how we're going to treat that patient. As I mentioned earlier, non-small cell lung cancer is the most common type of lung cancer. It has different subtypes, if you will: adenocarcinoma, and squamous cell carcinoma are the two most common. Large cell carcinoma is the third most common. So those are the non-small cell lung cancers. And when we talk about lung cancer, we don't just want to know if it's non-small cell or small cell. We want to know, does the patient have an adenocarcinoma? Does the patient have a squamous cell cancer? Because we make decisions about treatment based on accurately knowing what type of cell that cancer is. And then the second most common type of lung cancer is small cell lung cancer. Bronchoscopy is a test that we pulmonologists like myself, surgeons as well, thoracic surgeons do. And this is a tube, a fiber optic long cable, if you will, long tube, that allows us to visualize and see inside of the air tube. So here we are in the trachea. This is the left air tube and the right air tube. So we can see any abnormalities. Right here we have a mass, and here we have another mass in the air tube. And it's really, really helpful because we can directly biopsy these masses when we see them. The other important thing about bronchoscopy is that there is a different type of bronchoscope that has at the tip a little camera, and that allows us to, with a camera, look for lymph nodes that are outside on the other side of this air tube. So we can put the camera right here, find the air tube, and biopsy the lymph node. Find the lymph node and biopsy those lymph nodes. And that's important because that's a way that we also evaluate how much of this tumor has spread. Has it spread to lymph nodes? Because again, all of that information is so important when we make decisions about how we're going to treat our patients. Occasionally, the mass is in what we call the outer part of the lung, and it's very close to the chest wall, and we can ask our radiologist to put needles through the back and biopsy masses, and those are called lung needle biopsies. Sometimes the surgeons may have to go in, let's say none of this was here, and remove a nodule if we can get to it with any other technology. And then lastly, sometimes patients with cancer and other medical conditions will have fluid that accumulates outside the lung in a space called the pleura. And if that happens, particularly if we suspect cancer or we know someone has cancer, we put a small needle in and we drain that fluid so that we can test it appropriately and make decisions based on what we find when we test it. As I said earlier, PET scan helps us to look for cancer in other parts of the body beyond the lung because lung cancer can spread to many other organs. For example, if this is a lung cancer here, these are what we call the lymph nodes. So they're nodes that are outside the air tube. But you can have a cancer that spreads to the other lung. It can go to the bone, to the adrenal glands, which are these little glands that sit above the kidneys, or to the brain. So when we are evaluating patients with lung cancer, we get not only PET scans, but sometimes we have to get brain MRIs to evaluate the brain as well. We make decisions about how to treat lung cancer depending on the stage, meaning where has it spread to. If lung cancer is just in a lung and has only spread to the lymph nodes that are within that lung, that's called early stage. And surgery is the treatment of choice if the patient is able to have surgery. Sometimes patients with early stage will get chemotherapy after surgery, and that depends on what we find at the time of surgery. If lung cancer, let me go back one slide. If this is the cancer, but we find that the lymph nodes in the mediastinum, which is this space in the middle of the chest, if those lymph nodes are involved with cancer, then those patients are treated with a combination of chemotherapy and radiation. And then after they finish that treatment, the new therapies, immunotherapies, are being used. Sometimes patients can have chemotherapy and surgery. It's very much dependent on where the lymph nodes are and how many lymph nodes are involved. The majority of patients with lung cancer will present with stage 4, advanced cancer, meaning you have a cancer and it's spread to the brain or to another organ or to the other lung. And the treatment of stage 4 lung cancer very much depends on the cell type. So we need to know, that's why we're so cautious about biopsies and getting adequate tissue so that we make the best decisions. It could be chemotherapy. It could be special medications if the cancer has mutations. And these mutations are more commonly found in people who do not smoke, who develop lung cancer. So it's very important that we check for those mutations, particularly in non-smokers with adenocarcinoma. It could be immunotherapy, some of the newer treatments that are available, especially if the patients express a special protein in their tumor cells that let us know that immunotherapy should be done first. So many different options for patients with advanced lung cancer. Early stage lung cancer is treatable and curable. Patients with locally advanced cancer, treatable and potentially curable. And although we have not yet found a cure for stage 4, patients are doing much better and living longer because of improvement in treatments. As I mentioned earlier, it's very important to test patients who have adenocarcinomas of the lungs, particularly non-smokers, but we also check these tumors in smokers for special molecular mutations, because if these mutations are present, these patients are eligible to be treated with new medications. And it's important because treatment with those medications that are targeted to those mutations, has been shown to significantly improve 3-year, and now we're having small number of stage 4 lung cancers with 5-year survival. And it's also very important to test all patients with stage 4 lung cancer for a marker known as PD-L1, because that's a marker that helps us determine if immunotherapy can be given as the first choice of therapy. Small cell lung cancer is the second most common type of lung cancer, and it's either limited, meaning the tumor is confined to the chest, or extensive, meaning it's spread to the bone, the brain, the liver, the adrenals. The treatment for limited stage is the combination of chemotherapy and radiation. The treatment for extensive stage, when this type of cancer has spread outside the lung, is chemotherapy and or radiation to the bone or the brain if there are metastases or spread to those organs. Bone pain can be very difficult to treat. Radiation is a very good treatment to help patients with spread of cancer to bone. And lastly, we'll talk about screening for lung cancer, or early detecting lung cancer at an early stage. And for many years, we have been screening for breast cancer and for prostate cancer and for colorectal cancer, but we did not have an effective tool for detection of lung cancer. And there were a lot of studies that were done that just never demonstrated that if you looked for lung cancer early enough, that it actually made a difference in terms of decreasing the number of people who died from cancer. And fortunately, a very important study was done that was completed in about 2010, published in 2011. And this is a study that took 55,000 people who were at risk for lung cancer because of their age and because of the amount of tobacco they had smoked, or the number of years they had been quit. And half of the patients went on to get a chest x-ray, and the other half went on to get a test called a low-dose CAT scan. And what they found was people who got the low-dose CAT scan did a little bit better. Cancers were diagnosed earlier stage, so smaller in size. People were able to have surgery and less likely to die from lung cancer. So the risk of dying from lung cancer was less in the group that had the CAT scan versus in the group that had the chest x-ray. And this became very important because for the first time in a long, long time, the United States Protective Services Task Force, which is a task force that advises government and policies and Medicare about the appropriateness of tests, gave the low-dose CAT scan for lung cancer screening a grade B. And grade A means it works really well and the benefits far outweigh the potential risks. Grade B is it works, but there may be some risks. And what are the risks? Well, because CAT scans are so sensitive, it's not uncommon to pick up nodules, little shadows in the lung. But in the majority of patients, those shadows are not cancer. They are benign shadows. So it's a risk that we may be doing too many procedures or doing surgery for benign cancers. It's a balance. But this is an excellent modality for screening if people meet the criteria for screening defined by the United States Task Force. And what is that criteria? Individuals, and I should say that Medicare approved this test in 2015, as well as other insurance companies. Healthy. So the people who were studied in this study were very healthy people. Healthy individuals, 55 to 77 years of age, who have 30-pack year smoking history. What does that mean? It means a person has been smoking a pack of cigarettes a day for 30 years, or 2 packs a day for 15 years, or a pack and a half a day for 20 years. You add it up, and it should add up to 30 packs or more. And if they've quit smoking, they've quit within the last 15 years. So if you quit smoking 30 years ago, you don't fall into the screening criteria. There are some recommendations to screen older patients. There are differences in recommendations, but this is what Medicare has recommended. One of the most important interventions that we can do and one of the most important treatments that we can provide for our patients who smoke is tobacco treatment. Because tobacco is not an addiction. It's not a habit. It's not that people just, don't want to quit and are too lazy to quit. Nicotine is a drug, and this is a disease. And tobacco is a disease, and that's how we need to think about it. And we need to help patients by treating the disease. It's important because we know that when people quit smoking, for every 10 years that they are quit from their cigarettes or tobacco-free, the benefits in their health are numerous. Lung cancer risk goes down, heart complications such as heart attack risk go down, stroke, improvement in high blood pressure, improvement in diabetes, as well as reducing the risk of other cancers, breast cancer, bladder cancer, stomach cancer. So there are multiple benefits. But we must, when I say we as a medical community, help patients deal with this addiction and this disease. When we meet patients who are smoking and they're either undergoing screening because Medicare and all the other societies that have supported screening have said if you're going to do lung cancer screening, people who are smoking must be enrolled in a smoking treatment or smoking cessation plan. It's very important. And we have to not only ask and advise, but educate patients, give them appropriate information and counseling, which has been shown in combination with medicines that can help fight the addiction, be the best way to deal with tobacco. I mentioned lung cancer risk reduction and reduction in decrease in the risk of other cancers, but also very important, if smokers develop chronic lung disease and they stop smoking, the rate at which their lung function will decrease slows down quite a bit. So it's incredibly important and so beneficial in so many different ways. We think about lung cancer, or I should say not we, I certainly don't, but some individuals in the community think of lung cancer as a disease that, oh, it's so bad, it has no hope. There's a lot of what we say in our world, nihilism. And I really hope that someday we can do away with the stigma that patients have to feel and about, they smoke, therefore they got this disease. This is not about that. It's about helping individuals and helping individuals get to medical attention when they have symptoms. Because sometimes smokers get nervous and don't want to get medical attention. Making sure that even non-smokers with unexplained respiratory symptoms get to medical attention. And in the last 25 years, I've been taking care of lung cancer patients since 1992 when I was a fellow at Sloan Kettering. And I can tell you that between then and now, the advances are phenomenal, not just in improved radiologic studies like the PET scan. The PET scan's only been around since, the mid-2000s. Better CAT scans, the low-dose CAT scan for screening. These are studies that have really helped us in our evaluation of patients with suspected or known lung cancer. There have been significant improvements in procedure and technologies like bronchoscopy, that endobronchial ultrasound that allows us to sample lymph nodes has only been available since the 2000s. Surgery techniques are much better. Surgeons can now do surgeries without having to open up a chest with only small cuts on the side of the chest. They can do and remove parts of the lung with much less involved surgery. Radiation has also dramatically changed and improved. We now have radiation treatment known as SBRT or stereotactic radiation, which can help patients who are not able to go to surgery because they have advanced lung disease. And in the area of chemotherapy, the advances have been exceptional with the development of targeted drugs that target specific mutations. And more importantly, in the last 5 years, with immunotherapy making a big difference in patients with this disease. Thank you very much.
All right, and thank you, Dr. Rivera. And despite the devastation that this disease can cause, I hear a lot of hope in your message today in terms of treatment and diagnosis and the progress that's been made.
Absolutely.
Well, I want to remind our audience, you can join us for questions now by submitting those to Poll Everywhere. If you didn't already do that, 22333 with the letters UNCCN being sent, and you'll be joined. If you already did that, you can just go ahead and start submitting your questions. If you didn't bring a phone or a web browser, but your neighbor has one, ask him or her if you can go ahead and share a question there. You can also do that at the site as well. So let's go ahead and move on to our poll and see if we have any questions. I have one to start with while we're waiting for our audience to share their questions. If for people in our audience who are less familiar with oncology, explain the idea of a metastatic cancer. So if I have lung cancer and then it spreads to my brain, do I have brain cancer now?
No.
Do I have metastatic lung cancer that's moved to my brain?
Right. So when a cancer starts in one organ and spreads to another organ, that's metastases or metastatic or stage 4. And that's often a common mistake. People will say, well, they have bone cancer or they have brain cancer, but it's really the cancer started in one organ. Right. Most commonly lung, breast, and then it spreads to other organs. So metastatic means it has spread beyond the original organ it developed in.
So if that were to spread to the brain, then it would be metastatic lung cancer that is spread to the brain, not brain cancer.
That's right.
And I think that can be confusing with the oncology.
I think so. And we always say metastatic. It's lung cancer metastatic to brain. We always try to, now because the way that we stage lung cancer has changed, metastatic to adrenal, we like to say exactly where it has spread to and how many spots we see in that other organ. Metastatic cancer is also commonly referred to as stage 4 or advanced. At least in lung cancer, stage 1, 2, 3, but stage 4, it's when the lung cancer has spread to another organ.
All right. Thank you for that clarification as well. So I have a great question that's come in. Are there markers identified for family members to be tested?
No, we don't have any serum markers or genetic markers, unfortunately, that have yet been used in clinical practice.
All right. If you have additional questions, again, now's the time to let us know. And you can also just go to that POLAB site and share that with us there as well, or via the texting. So another question, in terms of a public health effort, where do the best efforts lie in terms of expenditures and what we can do to prevent moving forwards? Is that treatment of tobacco use? Is it education? Where are you seeing that those efforts can best be spent?
I think that the fight against lung cancer begins with the fight against tobacco. And there are phenomenal efforts that are being made by individuals and by organizations like the American Cancer Society and the American Thoracic Society and Free to Breathe. But we have enormous challenges because of tobacco policies and tobacco advertisement and the millions and millions of dollars that tobacco companies have that they can spend on promoting these drugs, because cigarettes are a drug. Yeah. And not just in the United States, unfortunately, but exporting these drugs to other countries. And the other thing that's very challenging is that the tobacco companies target minority individuals, they target blacks and Hispanics, they target people in poor communities. They tend to open up retail tobacco stands near schools so that children, it's been shown that children walking by these are more likely to pick up cigarettes. They provide coupons. There's all these incentives. So it's a challenge. But a lot of effort is there's funding for lung cancer research is not as robust as funding for breast cancer research and other research. It's always been it is the least funded cancer.
Really?
Yes.
Oh, that's surprising.
That's, again, I think it had a lot to do with the nihilism and the stigma, but that's changing. Drug companies have provided a great deal of the funding to do some of the more advanced and development of the drugs, the targeted drugs, and the immunotherapy in lung cancer. But there's a lot of work to be done in this disease.
Okay. Well, lots of other questions came in. Thank you so much to our audience. What are some of the most exciting developments in lung cancer detection and treatment currently under study?
Right now in lung cancer, it's whether or not certain tests can be used, blood tests that is, to identify individuals who might be at risk for lung cancer, but that's still very early. But more importantly, when nodules are detected, markers that can help determine whether that nodule is a concerning cancer or not. A lot of these are still in the investigative phase and not yet in clinical practice. Drug development is ongoing. New immunotherapy agents, combinations of treatments, chemotherapy and radiation with immunotherapy. Surgical techniques are advancing. Robotic surgery is something that's becoming more and more commonly done in lung cancer, so preserving more lung tissue and doing surgery with minimally invasive testing. And of course, screening. Screening for lung cancer in individuals who are at risk for lung cancer. Understanding that sometimes CAT scans will find nodules and that the majority of nodules are not cancer. But all these things are making a difference.
All right, thank you. Another question, what is the survival rate for patients with colorectal cancer metastasizing to the lung? And per our earlier conversation, this isn't lung cancer.
I'm
This
not,
is,
yeah. I don't know the answer
Sure,
to that. I'm
sure.
not an expert on colorectal cancer.
Sure, and I'd imagine there are a lot of extenuating circumstances around that. As a clinician, should we recommend family members follow any screening procedures such as the scans noted?
For screening for lung cancer, if the individual meets criteria for screening, that is age 55 to 77, smoking 30-pack years, and if quit within 15 years, then and they're not, they don't have severe COPD on oxygen or severe heart failure or severe comorbidities that are going to compete with death, then individuals should be referred for screening. But lung cancer screening is recommended, it's only recommended for individuals who meet criteria for screening.
All right, thank you. Next question, 2 years ago, wedge op, have nodules which haven't changed. Should I be concerned?
As long as if the nodules were benign and the nodules haven't changed over 2 years, that usually implies a benign nodule. I would advise you to continue your follow-up with your doctor as he or she has recommended.
All right, thank you. Mom died first. Mom first diagnosis. Sorry, I'm so sorry. Mom first diagnosis at 64, lobe removed. 5 years later, second lung cancer.
Another cancer. Yes.
Yeah.
So as I mentioned earlier, individuals who have one tobacco-related cancer are at increased risk of developing a second tobacco-related cancer, and that happens in lung cancer. You're treated, you're cured for one cancer, and 5-6 years later, you might be diagnosed. It's still rare, but it can happen.
All right. What about secondhand smoke exposure? My father smoked 2 packs a day. I was exposed to that till I was 13. I'm now 69. Are there long-term, I'm going to guess, after effects from that?
So the risk of lung cancer following secondhand smoke is slightly increased compared to someone who's never been exposed, but it's still pretty low. And the most common risk is really asthma, or especially in children, we worry about recurrent bronchitis. We don't really know the long-term effects once the exposure has diminished or has ceased.
All right. And the last question before we begin to wrap up, what percentage of patients are tested for PD-L1? Is it first line or with chemo?
So I don't know what percentage are currently being tested. About 20 to 22% of patients with stage 4 lung cancer have PD-L1 greater than 50%. So it's only about a quarter of patients who will have the test that shows greater than 50% expression. If an individual has greater than 50% of expression, then the first line treatment is immunotherapy. It's not with chemo, it's immunotherapy as first line. If they don't have greater than 50% PD-L1 testing, then chemotherapy is first line and immunotherapy would become then second line. But I don't know currently what percentage of the population is being tested.
And for our audience, PD-L1 refers to...
It's programmed death ligand. It is a marker of cells expressing this very important protein that responds to immunotherapy.
Okay, thank you. Thank you so much for a great, this has been wonderful, very informative. Thank you to our audience for taking the time to be with us today and for all of those great questions. I want to say a few more thank yous. I want to thank the generous support of the North Carolina General Assembly for what they do for the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. I also want to thank our team, Mary King, Veneranda Obore, Alan Brown, and joining us just last week, John Powell. So they all work very hard to make this and all of our other programs possible. We do want to remind our audience that we have a new learning portal, the UNC Cancer Network Learning Portal. That's at learn.unccn.org, and that's our new home for community education resources. You can also visit us at unccn.org and find information there as well. This is free and open access to recordings of our community lunch and learn lectures going back to 2017. At our regular site, you will also find other lectures, over 200 lectures now on oncology topics. All right, visit the site there, learn.unccn.org, browse the available courses, and sign up for a free account today. If you have any questions or problems with accessing that, unccn@unc.edu or call us at 919-445-1000. We're excited to announce our first lecture of 2018 with the Community Lunch and Learn series. That will be January 26th at noon, Supporting Adolescents and Young Adults Living with Cancer with Lauren Lux. So we hope you'll be here to join us for that. And until next time, thank you so much. Have a great afternoon. Thank you, Dr. Rivera.
Thank you.